are some of the most rewarding aspects of researching and working in DGBIs as opposed to having specialized in organic GI conditions?
I could start. People don't die from it. You have the opportunity to really help these people. I think that people, the stigma around it is that you can't help them. But the fact is that you can help with the proper tools, with communication methods, with the use of the newer medications. You can help people where others have not. I think all of us who in the field of neurogastroenterology, not just at the academic centers, see patients who've been to other community practices and they're just miserable. They don't feel good at all. They feel dismissed. And just by having a proper relationship, a good patient-doctor relationship, and by coming up with the modern treatments, you can help them where in some of the organic diseases you may not.
I guess I'm very impressed with working with patients with incontinence, for example. Simple procedures can often make a big difference to their lives, and they're very grateful for that. And it's really gratifying to see that.
Just going back to a former question, I know that Doug wanted me to bring this up at some point. When I began all of this, IBS was considered a disease that wasn't worth people's time. They used to, believe it or not, admit people to hospital for it. And very often on rounds, a senior professor would assign the most junior intern to go and talk to the IBS patient simply because he didn't think it was worth his time. I thought this was a very, very bad attitude, and I saw it from many different aspects when I was a student and a resident and a fellow in London. And I think that one thing that Rome has accomplished, that the whole process, the work that Ken and I did and then Rome, was to destigmatize it. Nobody now thinks it's shameful to have the IBS. And I don't know why such an attitude could develop, but it was there.
Thank you for saying that. It's very important.